This program is brought to you by Emory University.
Today we have Dr. Kumar, who's going to be presenting to us about the introduction to echo. Dr. Kumar is a fantastic educator. He is an interventional cardiologist based out of the VA. He also does some structural interventions. What's amazing about Dr. Kumar is that he also is level 3 echo trained from the Mayo Clinic. And so he is able to combine both interventional cardiology and his background as a level 3 echocardiographer. And he usually gives fantastic talks, and we're very happy to have him give our introduction to echo talk this year. So thank you again, Dr. Kumar.
All right, good morning. You may hear some extraneous noises in the background that actually are my kids attempting to wake up. So if they do wake up, or they may make a grand appearance, you know how that goes. So we're going to start with a little test. I don't know how the videos are going to play on your screen. We're going to have 15 questions, 1 minute per question. I'll go through the answers right after. And this is just to kind of get you warmed up. There in all kinds of order of difficulty. Some are harder, some are easier. You can go through it. And remember, keep calm and carry on. All right, so here's the first question. Which of the following structures is not visualized in this image? And I can scroll back to the answers. And I call upon Maya, if she's out there, to unmute yourself and tell me what you think. I'm going to show the image, and you tell me which of the following is not shown in the image. Okay? You there, Maya?
Yep, can you hear me?
Yes, I can hear you. Good morning.
Good morning.
So which of the following structures are not shown in this image? First of all, tell me what this image is.
It looks like an apical 4-chamber view.
Mm-hmm.
And I don't see the aortic valve, so B.
Correct. The apical 4-chamber view, you don't see the aortic valve. That's excellent. Well done. All right. Off to a good start. Okay, second question. Things are getting a little bit more difficult here. Errol, are you out there?
Right here, Dr. Kumar.
All right, good morning.
Good morning.
So the second question is, what probe movement is needed to go from the first image to the second image? Okay, so I'm going to show you the images, and the probe movements are at the bottom. And let me see if I can hit play, and here we go. That's the first image, and this is the second image.
If you have to take, for example, it is a clockwise rotation.
That's correct. So you're going from a parasternal long axis view to a parasternal short axis view, and so what you need to do is a clockwise rotation. Errol remembers. Excellent. Good job. So question 3. Which one of the following is the most likely value of this patient's right atrial pressure? 0, 3, 8, 15, E unknown. And here we go. And is John there? John?
Yes.
Hi,
Yeah.
John. Good morning.
Good morning.
What do you think is this patient's right atrial pressure? Are you able to see the screen? Hello? Did I lose everybody, or did I just lose John?
I think you might have just lost John.
Okay. All right. I guess I lost John.
Wait, hey, no, hey, can you hear me?
Hi, John. Welcome back. Yes. I can hear you.
Because it really doesn't look like it's collapsing by 50%.
Yeah, it does not collapse. So you're right. 15 is correct. Maybe the video is choppy on Zoom. I'll try and avoid videos if I can. How do the videos play for you guys remotely? Is it pretty choppy? Okay. Okay, good. So that's 15. Okay, next question. Fernandez.
Yep.
Good morning.
Good morning.
So based on this image taken from a dyspneic and hypotensive patient, which one of the following procedures is unlikely to be of benefit? A, central line placement. B, abdominal tap. C, pleural tap. D, CT chest PE protocol. Or E, pericardiocentesis.
Well, it looks like there's fluid posterior to the descending thoracic. So unlikely that pericardiocentesis would be helpful.
Good. So I think everyone needs to realize something that Marcelo is trying to point out here, which is, if you look, this is the descending thoracic aorta, this is the vertebral body, and this, oh, you all can't see whatever I'm pointing at, can you?
We can see it.
Oh, you can see the pointer. Okay. So this is actually a pleural effusion back here. A pericardial effusion should be up here. This tiny little sliver here is a pericardial effusion. And basically, as you can see, there's not much pericardial fluid. So it's unlikely that pericardiocentesis is going to help this patient. Excellent. Good job, Marcel. All right. Easy question here. Let's see, I gotta find myself a victim first. All right, Logan. Is there, Logan?
Hi, good morning. Yes, good morning.
Logan. How are you?
I'm good. How are you, Dr. Kumar?
Good. So let's look at this question. Ultrasound waves are assumed to travel through soft tissue at the speed of 330, 40, 80, 1540, 300 million, and 33.
It's 1540.
That's correct. Logan is right. He killed it. 1540 meters per second. What is 330, Logan?
Is that through? I actually don't know what 330 is.
Air.
Air?
Yes. Speed of sound in air is 330. 480 is like a solid, like a wood block. 4080. Sorry, 4080. The 1540C is ultrasound. And that underlies all the assumptions that go into all of our ultrasound machines. The 300 million meters per second is the speed of light in a vacuum. That's clearly not the correct answer. And 33, I just threw it in there for the fun of it. Good job, 1540. All right, slightly harder question. And let me hunt down an advanced fellow. And yes, I can see. Oh, excellent. Al-Badri is there. Al-Badri.
Yes, sir.
Yes, good morning.
Good morning, sir.
Please arrange the following echoes in the order of increasing LV systolic function from lowest to highest.
Lowest to highest. 2, 3, 1. Is there an option C?
Yes, there is an option C. You're correct. So the lowest is number 2, where I would rate this function, and this is thrown out there so that the more junior fellows can train their eyes. Number 2 is probably the lowest. I would say that the LV function here is about 10-15%. 3 is in the region of around 30, 35, 40%, somewhere in that region. And 1 is about 65 to 70%. So the correct order would be 2, 3, and 1. Perfect. All right. We keep rolling. All right. Anurag, my cat fellow.
Hey, Dr. Kumar. Good morning.
Good morning. So which one of the following structures is not visualized in this image? Interventricular septum, interatrial septum, mitral valve, aortic valve, right ventricle.
The interatrial septum, B.
Correct. B. Interatrial septum is not visualized in this image. This is a parasternal long axis view. You have right ventricle, you have left ventricle, mitral valve, aortic valve, aorta, and left atrium, no interatrial septum. Well done. Okay, about halfway through. All right. Nick Shekladze.
Good morning.
Good morning. Based on these images, which of the following findings does this patient not have? A, RV enlargement, pericardial effusion, RA enlargement, severe TR, RA thrombus. Okay, here come the images. And then if you want, I can go back to the choices. So remember, the question is, which one of the following does this patient not have?
Can you go back to options?
Sure. Options are RV enlargement, pericardial effusion, RA enlargement, severe TR, and RA thrombus.
Answer is RA thrombus.
That's correct. So this is a PE, basically. Unfortunately, the patient doesn't have a right atrial thrombus. And actually, this was not taken, this was a fairly chronic PE. It's not taken in an acute setting. The patient had already developed some level of pulmonary hypertension and RV dysfunction. You can see the RV is very poorly contractile here. And for those of you, there is almost a D-shaped septum. The pericardial effusion, whenever they bring up this issue of pericardial effusion in pulmonary hypertension patients, Dr. Bhatt will tell you that's always poor prognosis that goes with that. So that's another thing to remember. All right. Okay, let's see. Find myself another victim. Ankit. Ankit not awake. Ankit, good morning. Okay, so Ankit is not awake yet. All right. Okay. Let's see who else is out there. Elena Dolmatova, are you there?
Can you hear me? I'm here.
Oh, who's this? Who showed up? Is that Ankit?
Yeah.
Okay, don't worry, Ankit. You're first. Then after you will be Alina. Don't worry. I haven't forgotten. So, Ankit, this is a question for you. With increasing probe frequency, which one of the following changes is not expected? Decreased wavelength, decreased attenuation, increased axial resolution, increased lateral resolution, and decreased depth or decreased depth of penetration. Classic physics question will show up on echo boards, except the knot will be turned around into a positive question. All board questions don't have knots anymore. I got to write better questions without.
Yeah, I'm not sure on this one. Is it B?
Yeah, it is B. That's correct. Good job, Ankit. So, as you know, wavelength and frequency are related. As frequency goes up, the wavelength has to go down. So A is definitely expected. Okay. C, axial resolution is actually related to the frequency. The higher frequency actually produces better axial resolution. Axial resolution is the ability, I don't know if you can see my pointer, is the ability to resolve objects that are in the same line. Lateral resolution is the ability to resolve objects that are next to each other. And so both of these are improved by increased frequency. With increased frequency, you actually have more attenuation and actually decreased depth of penetration. So E is true, and B by logic, opposite logic, B is therefore not true. So decreased attenuation is not true. You have increased attenuation when you increase the probe frequency. This is a classic board question that will show up in some way, shape, or format. Okay. Alina, good morning.
Good morning.
Which one of the following structures is seen in this patient's right atrium? A, defibrillator lead. B, thrombus. C, eustachian valve. D, Swan-Ganz catheter. E, Chiari network. Here's the picture. So which one of the following is that structure seen in the right atrium?
Looks ugly.
I agree. So what is it?
It's not a defibrillatory lead or Swan-Ganz catheter. At least it doesn't look like any sort of lead catheter to me. Can it be a thrombus? Could be.
Okay.
And I'm not sure about the rest, but I think I would bet for thrombus.
You're correct, Elena. It is a thrombus. You're absolutely right. This is a large right atrial thrombus in transit on its way to becoming a PE. And looking at this poor RV function, I can tell you that another piece of the thrombus is already up in the lungs. Okay, and the other thing that goes along with the fact that this is more acute is that the patient is tachycardic, heart rate almost 100 right there. Okay, great. Well done. Question 11. All right, let's see. Errol, I've already called on you, so don't worry. It's okay. Relax.
Okay.
Dustin, you're awake? Hi, Dustin. No, Dustin not there, sounds like. Okay, who's BK? Oh, maybe BK is Kunal. Yikes. All right. Okay, anybody else out there? Akanksha, yes. Are you awake?
Hello. Yes, Dr. Kumar. Good morning.
Oh, who is this? I guess Dustin said that. Okay, let me pick on Dustin first.
Okay.
All right. Dustin, so let's see. All right. Which one of the following cardiac views is not correctly named? A, parasternal long, B, parasternal short, C, right ventricular inflow, D, apical 4, E, apical 2. Okay, I'll go through it again while you're looking at the image, okay? A, parasternal long, B, parasternal short, C, right ventricular inflow, D, apical 4, and E, apical 2. Which one of these is not correctly named, Dustin?
C.
What did you say?
I said C.
No, it is D, Dustin, D as in delta. So A is the parasternal long axis view. We all know that. Clockwise rotation gives you B, which is the parasternal short axis view. And C is actually the RV inflow view. This is the right ventricle. This is the right atrium. Tricuspid valve is right there. So that's C. So that's correct. D is actually.
Oh, you're correct.
Yeah. Thank you.
Sorry.
D is actually the, it's tilted up from the, well, it can be an apical 3-chamber view or a 5-chamber, but it's not a 4-chamber view. E is definitely a 4-chamber, definitely a 2-chamber view, correction, 2-chamber view. All right, so the answer is D. Good. All right, Akanksha, I did not forget you. Good morning.
Yes, Dr. Kumar, I'm here.
Which one of the following structures is not visualized in this image? A, pulmonic valve, B, tricuspid valve, C, mitral valve, D, interatrial septum, and E, main pulmonary artery.
It's mitral valve.
Correct. Yeah, Akanksha is right. C, mitral valve. So this is a short axis view at the level of the aortic valve. Basically, this is just above the mitral valve in the short axis views. And you can see that the aortic valve is nicely seen, the pulmonic valve is nicely seen, the pulmonary artery is nicely seen, the tricuspid valve is nicely seen. This is the right atrium. This is the RV outflow tract. This is the left atrium. This is the interatrial septum. You do not see the mitral valve. Excellent. All right. Okay, let's see. Any other first years out there? Nobody's going to own up, but let me try my luck. Any first years out there?
I'm here, I guess.
Okay, Aditi, yes. All right. With reference to the usage of ultrasound gel, which of the following is false? False. may result in infection if contaminated. Improves image quality by decreasing reflection. C, improves image quality by decreasing acoustic impedance mismatch. D, helps to cool the transducer. Or E, improves image quality by decreasing refraction. What do you think, Aditi?
Not sure actually. Is it B, improves image quality by decreasing reflection?
No, try again. So now you're 25%. From 20%, you have 25% chance of getting it right. Improve by 5%.
Is it refraction?
Okay, that's also not right.
Oh,
Those
God.
are all true, by the way.
Okay. Helps to cool the transducer.
Yes, good job. It does not help to cool the transducer. That is false. So there have been infections reported from contaminated ultrasound gel. Actually, surprisingly, believe it or not, it was not for transthoracic, it was for TEE. So, you know, in general, if you try to do TEE, be aware that the bottle may be contaminated. That can be an issue sometimes. So, you know, at the VA, at least, we've gone to using these throwaway packs of gel. Anyway, image quality is improved by decreasing reflection so that you don't get reflections at air boundaries. Acoustic impedance mismatch is definitely improved by the gel, and image quality actually is improved by decreasing refraction as well. So the answer is D. It definitely doesn't help to cool the transducer. Good job, Aditi. Okay. Let me go to question 14. And here we are at question 14. And who do we have? Is Dev there?
Yeah, I'm here.
Okay, great. All right, this is for you. So, and then next question will be my good friend Dan. Okay, Dan, you're next for the last question. So 50-year-old man presents with shortness of breath and hypotension. ECG is negative for ST segment elevation. You intubate and mechanically ventilate him. Based on these images, which of the following would you do next? IV fluids, CT chest, pericardiocentesis, pleural tap, emergent care. So Dev is going to tell us what is he going to do next.
I would give IV fluids.
Correct. And what is the basis for that?
It looks like there's a hyperdynamic LV, tachycardic, and collapsed IVC.
You got it. Good job. Excellent. IV fluids. Okay. All right. Dan. Dan, good morning. Okay, maybe she isn't there.
Hello.
Ah, there you are. Yes. Good morning, Dan. How are you? Okay. Well, what happened here? It was playing a second ago, and now it's not playing.
Address E.
Ah, okay. Now it's playing. Perfect. Okay, Dan. Here's the question. Calculate the RVSP.
Okay, so the TR signal is 22. So, but he has like a dilated IVCs. I'm assuming, I'm not sure it's like a collapsed or not. So I'm assuming.
Not collapsing.
So we are adding like a 15. So it's around 37.
Okay, so you think D is the answer?
Yes, it's a
Okay.
trap.
All right. Let's see if we can find a random third-year fellow lurking around. Actually, yeah. Do we have a third-year fellow lurking around, other than anyone I've picked on so far? Blank, are you there?
I'm here, Dr. Kumar.
All right, what do you think, Blank?
The TR looks pretty wide open. And the question is whether you're actually getting it coaxially, and it may be higher than what the TR signal that you're getting. Is that what you're going after?
I wasn't going after that, although that is also a valid point. The answer here is actually E, because you have severe TR, and look at the TR waveform. What is funny about this TR waveform?
Very sharp.
Yeah, it's not a rounded envelope.
It's not a rounded envelope. This is a sharp envelope. It looks almost like a LVOT ejection signal, right? So that tells you that this is a non-restrictive orifice. So when you have a non-restrictive orifice, some of the assumptions that underlie the Bernoulli equation that enable you to use the delta P equals 4V squared formula that Dan was using, which appropriately, are not quite valid. So this RVSP is definitely not 37. It is way more than 37 millimeters mercury. So just remember, when you have severe TR and you have this kind of envelope, the TR velocity may be underestimated by using the TR jet. Okay?
Right.
Yeah, so the answer here is D. Cannot be precisely determined based on data shown. All right, so that is where we are with this. I'm going to share you another PowerPoint presentation if it will open. Okay, good. Are you able to see the screen? Yep, perfect. Okay. All right, so now we move on to the more didactic portion. No more questions, so you can mute your microphones and happily go to sleep. We're going to briefly talk about the history of ultrasound, some basics of ultrasound physics that we went through, basic cardiac views, how do you calculate stroke volume and cardiac output, a little bit about pressure gradients. There's stuff in there about regurgitant lesions. I think you guys should have this PowerPoint. If you don't have it, I can give it to you. So there's some stuff in there that you can read and calculate by yourself as well. So if you look at the history of ultrasound, it's interesting that I find that the Doppler effect was actually discovered prior to the discovery of ultrasound itself in 1842. The piezoelectric only described by Curie in 1881, which incidentally, the Curie spouse, husband and wife were also involved in the discovery of radiation as well. So between the two of them, they have probably discovered almost all of the physics behind the modalities that we use in cardiology, interestingly. The hydrophone was described in 1916, and subsequently the development of B-mode, Doppler, and 2D echo. So ultrasound basically is sound waves above the audible frequency in say anything between 20 hertz and 20 kilohertz is what you can hear. The ultrasound frequency is above 20 kilohertz, but most of the clinical useful ultrasound is between the 1 and 20 megahertz range. To give you some idea of range, between 1 to 2 megahertz is all the therapeutic ultrasound. You get some abdominal cardiac probes that go between 2 megahertz and 5 megahertz. Vascular probes usually 4 to 6, 7 megahertz. Ophthalmic probes 10 megahertz. Your intravascular eagle eye IVUS probe 20 megahertz. The HD IVUS probe 45 megahertz. So that should give you an idea of where all these ultrasound transducers lie in terms of their frequency. TE probe generally is in the range of 8 to 10 megahertz. So what is ultrasound? So if you think about ultrasound, you have the sound coming from, the pulse coming from the transducer, hits the object, comes back, travels with the velocity V that we know now is 1540 meters per second, as you can see. And the distance is 0.5 times time times velocity, and therefore you know where the distance is, and the machine calculates that. Transducers, as you know, come in a variety of shapes and sizes. It's important to note that the probe is listening about 99% of the time. Ultrasound has different tissue interactions, reflection, refraction, transmission, and scatter. In general, the usage of gel improves impedance mismatch, which helps with this. So in terms of tissue characteristics, air is a strong scatter reflector, fluid is a propagator, bone is a strong specular reflector, and soft tissue is a partial reflector. It's ideal for ultrasound imaging. You get an echo whenever the impedance changes. So in terms of display modes, this is kind of historical, but last year I said this as a final Jeopardy question for the Georgia ACC, and I don't think anybody got it right, unfortunately. So hint, hint. So now you know, A mode stands for amplitude, mode stands for brightness, M mode stands for motion, and Doppler is, well, Doppler. Okay. If you look at image acquisition, orientation, depth, gain, and time gain compensation, these are the things that we can vary in terms of optimizing our image acquisition. In terms of orientation, you got to know your anatomy. You got to know the mark on the where on the mark on the probe corresponds to the mark on the screen, and you have to basically do your exams. The greater the depth that you have on the screen, you have less line density, less lateral resolution, and less frame rate. So if you're going to image the heart, don't do it at maximum depth. You know, you can do a maximum depth to look for pericardial effusion or looking below the heart, and then after that, optimize the depth. Okay. Gain, it's typical when you're starting out, you tend to overgain your image. That's just a display on the screen. So, you know, to have optimal gain allows for maximal contrast resolution. So just remember that. Time gain compensation is the fact that the signal gets weaker as time passes. So the deeper images are more attenuated. So you can have near and far field gain on the site, but on the Philips, string of little gain adjustments that you can adjust. So remember, this is how you orient yourself. Doppler effect is when sound is moving towards the receiver, the apparent frequency is higher than if the sound was stationary, and vice versa. So what we do is blue flow, we state it as by convention as away from the transducer, and red is towards the transducer. These are all different that you can obtain, and I will scroll through them in the interest of time. Stroke volume is calculated by measuring the LVOT diameter with the LVOT pulse wave VTI, and you do 0.25 pi d squared multiplied by the LVOT VTI. Okay, so that's how you get stroke volume. Cardiac output is then heart rate times that stroke volume. You can calculate pulmonary to systemic ratios by calculating all of these parameters, and you can then get acute by echocardiography. We measure translesional aortic valve pressure gradients by doing continuous wave Doppler through the aortic valve. We can get the mean gradient, the peak gradient, and or the jet velocity. And this is an example of that. It's important that you minimize the Doppler angle and be as in line with flow as possible, as Evan pointed out to us earlier. If you're off by as little as you can miss close to, based on this cosine curve down here that you can see, you can miss close to 15% of the signal if you're off by 30 degrees. It sounds like, oh, 30 degrees is so little, but that's actually a big deal when you talk about something, you know, you talk about the rib cage and the body and your sort of body habitus, etc. In general, when it comes to mitral valve Doppler gradients are generally more reliable than aortic because you got a very good Doppler angle, and you can see some good mitral valve Doppler gradients that are measured both by TE and by TTE, and these gradients are about the same. There are multiple different ways of measuring valve, planimetry, continuity equation, PISA, and pressure half-time methods. We can go through different examples of these. Just remember, this is just an outline. Again, you know, you'll be going through examples of these in each of your cases. Right atrial pressure, we talked about. In general, we look at size and collapse. If it's less than 2.1, collapse more than 50%, it's 3. If it's greater than 2.1, less than 50%, it's 15. And then, you know, if it's intermediate, you look at secondary indices, restrictive filling, diastolic flow, and hepatic veins, etc. Assign a number of 8. And that's the same example that you had earlier, and how you calculate RVSP. We already went through that. This is a whole list of other things that you can calculate based on Doppler estimation of pressures. In terms of regurgitant lesions, you have qualitative methods and quantitative methods of quantifying regurgitation. Qualitative methods, you just look at color flow Doppler. Quantitative methods, you can have continuity method and PISA. There are other things that you can do in terms of hemodynamic arrangements. You can look at fluttering of the mitral valve, mid-systolic aortic valve closure, D-shaped septum that we talked about this for increased RVSP. You can look at cardiac tamponade. That's an important thing that you need to be able to recognize. Finally, I believe that the universe of echocardiography has been created. Unfortunately, this has made a lot of people very angry and generally has been considered to be a very wide move. Thank you.
The preceding program is copyrighted by Emory University.